Thank you for the opportunity to present our work. We have no disclosures. So as we know, G-tubes are typically used to maintain hydration and nutrition and can also be used for medication administration. And there's historically been a high rate of concomitant gastrostomy tube placement and anti-reflux procedures if there is concern for reflux. This is particularly true in patients with neurologic impairment who are known to have higher reflux rates, most likely secondary to upper GI dysfunction, reduced GI motility, and gastric emptying. For example, in some patients with cerebral palsy or Rett syndrome, this is true. However, reflux, especially in the neonatal period, is often temporary. The lower esophageal sphincter matures, as well as the angle of His, and the reflux resolves. So that raises a question, why are we doing a permanent surgical procedure for a sometimes temporary problem? So our goal was to determine the rate of concurrent fundoplication in kids with and without neurologic impairment at the time of the initial gastrostomy tube placement, as well as the rate of future anti-reflux procedures in children undergoing isolated gastrostomy tube placement, comparing those with neurologic impairment to those without. So we hypothesized that children with neurologic dysfunction have a higher rate of initial concomitant fundoplication as well as a higher rate of future fundoplications. So we used the Pearl Diver Mariner database, looking at children under the age of 18 and if they had a gastrostomy tube placed, and we determined this via CPT codes. And we looked at the years 2010 to 2020. And then we compared patients with and without neurologic dysfunction undergoing initial concurrent fundoplication as well as future anti-reflux procedures. We define neurologic dysfunction as patients having cerebral palsy or degenerative neurologic disease based on ICD-9 and 10 codes. And then having a future anti-reflux procedure was defined as having a fundoplication or a gastrojejunostomy conversion or either after that initial gastrostomy tube placement. And then we use Kaplan-Meier analysis log rank tests and Cox proportional hazard regression modeling to look at the significance. So we found 16,000 patients who underwent initial gastrostomy tube placement with a median follow-up just shy of 4 years. We found 7.2% of these patients had a concurrent fundoplication at the time of that initial G-tube. What was significant is that children with neurologic impairment had a higher rate of concurrent fundoplication at 9.3% compared to 6.4% in those without. However, concurrent fundoplications are declining over time. Initially, back in 2010, rates were over 15%, and currently they're less than 5%, and this was true in both groups. But still, it seemed like, or we found that in children with neurologic impairment, there still was a higher rate of secondary anti-reflux procedures at 12.6% versus 8.6%. And this was true whether it was fundoplication, a GJ conversion, or either. So children with neurologic impairment undergoing isolated gastrostomy tube placement had a significantly higher rate of requiring an anti-reflux procedure at 5 years as compared to those without. So in conclusion, concomitant fundoplication is more often performed in younger kids and those with neurologic dysfunction, but it's declining overall. Children with neurologic dysfunction are more likely to require a secondary anti-reflux procedure, but these rates of requiring a future anti-reflux procedure are low. It's less than 15% amongst all children. So even though this cohort's more likely to require a secondary procedure, it provides support for not performing a routine anti-reflux procedure in asymptomatic children at the time of initial gastrostomy tube placement. So thank you for the opportunity to present, and if anyone has questions, I'd be happy to answer.
So I just want to ask a question. So you measured the patients who got a Nissen after having a G-tube, but you didn't measure the patients that needed a Nissen after having a G-tube. So how did you account for patients who had acute life-threatening events or perhaps died when they could have had a fundoplication?
We weren't able to assess that with our database, so it's something we could look at in the future.
I enjoyed that, and I want to congratulate you. My question is that you looked at patients who had the G-tubes with the Nissen, but was it possible to determine these are patients who had an indication for a G-tube and then had the Nissen added on, Or were these patients who had an indication for a Nissen and had a G-tube done with the Nissen concurrently?
Yeah, I think that's a great question. Thank you. Unfortunately, using a database, one of the biggest downsides is the lack of granularity of data. And looking at the ICD codes alone, it's difficult to determine that. But that's a very good point.
Okay, thank you.
Thanks.